morning, everyone, and selamat sejahtera. I'm Dr. Koh, the moderator for the edition of Breakfast at UMHealth today. So the first session today, the talk will be on transcranial magnetic stimulation for treatment-resistant depression. So just a bit of background for this topic. So major depression is a significant public health concern in Malaysia, with prevalence rates steadily increasing over the years, and despite the advancement of psychopharmacology for depression, around 30% of patients do not respond adequately to first-line antidepressants. So transcranial magnetic stimulation, or TMS, is an FDA-approved neuromodulation therapy for difficult-to-treat depression. So now it gives me great pleasure to introduce our speaker for the first session today. Our speaker is Dr. Hemavathi. So she's our newest and one of our newest and dynamic lecturers in our department. So she has been attached to the neuromodulation clinic in UMMC, and she also actively collaborates with the rehabilitation team to provide transcranial magnetic stimulation, or TMS, for patients with mood disorders. She is also a member of the Clinical TMS Society and completed her TMS certification in the United States this year. So without further ado, I would like to invite Dr. Hema to take over the podium.
Good morning, everyone. I'm Hema, and thank you for the kind introduction, Prof. Koh. So today I'll be presenting on transcranial magnetic stimulation, which is a form of neuromodulation therapy for treatment-resistant depression. So I'll be taking you through today on the challenges that we currently face in management of mood disorders. What is TMS, its basic principle, and how and why do we prescribe TMS for treatment-resistant depression, and as well as the early experience of providing TMS service at UMMC. So before we move to treatment-resistant depression, we need to recap what is a major depressive disorder or major depressive episode. So based on the DSM-5 criteria, so for us to diagnose a patient with a major depressive disorder, they have to have persistent depressed mood for 2 weeks or more associated with loss of interest or pleasure, and with 5 other symptoms such as changes in sleep, appetite, poor focus, feeling of worthlessness, hopelessness, and as well as recurrent suicidal thoughts or a self-harm attempt. And this impairment, this symptom should cause clinically significant distress or impairment in the socio-occupational functioning. So the thing about major depressive disorder is a very heterogeneous disorder. Plus, every patient may present with different clinical features, and oftentimes they have a lot of comorbidities, which make the treatment even more complex. So what is treatment-resistant depression? Is when the patient has failure to achieve a response with 2 or more antidepressant therapy during the major depressive episode at adequate dosage or adequate duration. So response here meaning at least 50% reduction of the depressive symptoms. So if we look at one of the landmark studies in psychiatry, which is the study trial, when we look at the steps of treatment, when the patient moves from first line, second line to third to fourth line, the cumulative remission rapidly reduces. And even after fourth line of treatment, around 30% of patients still remain symptomatic. So this brings us to other alternative therapies besides on existing pharmacotherapy and as well as psychotherapy for depression. So the local and as well as international guidelines are now recommending neuromodulation therapy. For example, TMS, which is recommended as a first-line therapy if patient has failed 2 or more antidepressant medications. So in psychiatry, there are many neuromodulation therapies. I'm sure you've probably heard about ECT or electroconvulsive therapy, which is a well-established treatment option. For the purpose of today's talk, I'll be focusing on TMS or transcranial magnetic stimulation. So what is TMS? TMS is a non-invasive form of neuromodulation technique. It does not require anesthesia like ECT. It can be done as outpatient procedure. It's a neural circuit-based therapeutic tool with minimal side effects. So TMS concept was first introduced by Professor Anthony Barker and colleagues in 1985. So TMS actually delivers a rapidly changing magnetic field delivered through a coil, and this will induce an electric field underneath the cortical neuron under the coil. So this is based on the Faraday's principle of electromagnetic induction. So we personalize patients' TMS treatment based on their individual resting motor threshold because it varies across the individual, and most resting motor threshold is defined by the minimum energy that we need to produce contraction of the muscle, for example, like contraction of the thumb. So this motor threshold measures the general cortical excitability and is used to give the treatment protocol so that it's safe and as well as effective for individual patients. But the question is, how does neuromodulation helps to alter the brain circuit and why is it important? So for that, we need to understand the pathophysiology of depression. So depression has been traditionally known as a dysfunction of the neurotransmitter system. So for example, low serotonin causes depression. So we give medications such as SSRI or serotonin reuptake inhibitor to increase the serotonin, hence improve the depressive symptoms. But over the years, based on research and also findings from resting functional MRI, we also find that depression or other mood disorder is also a network level dysfunction. So I'll be describing about this triple network dysfunction that is one of the area that we look into when we're giving neuromodulation treatment. So we have what we call the default mode network. So default mode network is, let's say, when you're at rest, you have a lot of self-referential thinking. So in patients with depression, there is hyperconnection in the default mode network. So this will give rise to symptoms such as a lot of rumination, worry, and also feeling of overwhelm. And at the same time, the salient network that's supposed to act as a switch, this is also not a dysfunction, so that it will amplify the distress and cause a lot of anxious avoidance symptoms. And the central executive network, mainly controlled by your dorsolateral prefrontal cortex, which is the central executive network, that is hypofunctioning or reduced in connectivity. So this will lead to a lot of cognitive dyscontrol. Patient has difficulty with poor concentration and also decision making. So what happens is patients who are depressed with this triple function network dysfunction, they will have a lot of negative thoughts. They amplify their distress and as well as their poor cognitive dyscontrol. So how do we modulate this network to help improve depressive symptom? So this is where TMS come into play. So we use transcranial magnetic stimulation to modulate the networks. So the networks that we can modulate here, that is actually reachable within the TMS magnetic wave, will be the DLPFC area that's frequently being targeted. So when DLPFC, we use stimulating protocols to enhance the connectivity at of the CN or Central Executive Network. This will rebalance the connection at other networks. And another important thing to note is why do we give treatment for depression at the left dorsolateral prefrontal cortex is because of this negative correlation with a very important area, which is called the subgenual anterior cingulate cortex, which is a crucial hub for emotional processing. And researchers have consistently found that this subgenual anterior cingulate cortex in depressed patients is hyperactive, leading to a lot of depressive symptoms. So besides, when we stimulate the DLPFC, it enhances the central executive network, but at the same time, it downregulates the subgenual anterior cingulate cortex, relieving the depressive symptoms. So this is the basic neuroscience of how does the neuromodulation help to alter the brain circuit. And how do we do it? So like I mentioned, we deliver a magnetic pulse through the coil. So when we deliver single pulse, it's more of diagnostic purpose. But in order to modulate the neuronal activity, we have to give it in a repetitive pulses. And these repetitive pulses can be given either as a low frequency, such as 1 Hertz, which serves as an inhibitory, and also as high frequency, such as 10 Hertz, that serve as an excitatory. So for depression, the conventional protocol that we use is high frequency, which is 10 hertz repetitive stimulation over the left dorsolateral prefrontal cortex. And the energy that we give is 120% of patients' resting motor threshold. And it's given 5 times a week. And patients usually need about 20 to 30 sessions to achieve good response and remission with the treatment. So means the treatment can last for 12 to 6 weeks duration. And the newer treatment protocols been FDA approved as well is intermittent theta burst protocol, which is also delivered over the left DLPFC, but this delivers a short burst of 50 hertz, but it's packed in a 5 hertz interval. And this 5 hertz interval actually mimics the natural theta rhythm of our brain. So it induces plasticity and also it helps. I mean, it's also equally effective like the conventional protocol, but the added advantage is only delivered in 3 minutes, but the duration is still the same. We still need to give 4 to 6 weeks of treatment. Hence, there have been newer research. For example, at Stanford, they did an accelerated or same protocol where they delivered 10 sessions of theta burst protocol in a day with a 15 minutes interval between the session. And but this was done in guided by functional MRI and also the neuronavigation targeting system. And they found the very good, promising remission rate. But at this point, it's still, more at the research and not really clinically we've not been practicing this yet. So transcranial magnetic stimulation, when we give repeated stimulation, it doesn't just act during the treatment period, but it induces neuroplasticity beyond the treatment period by causing functional changes such as long-term neuron potentiation or depression, and as well as structural changes such as neuronal growth. So as for psychiatry, in terms of the RTMS that has been approved for psychiatric indication, the first approval we got was in 2008 for treatment-resistant depression. So the TMS has been there in even overseas for about 20 years already. And in Malaysia, probably in the last few years, we are more active to provide treatment for psychiatric patients. And for OCD or obsessive compulsive disorder, the approval was gotten in 2018. And more recently in 2020, we got approval for smoking cessation as well. So, sorry. But of course, like I mentioned, that you need to deliver the magnetic field using a coil. So the traditional coil that we use is the figure of 8 coil, but that has penetration about less than 1 centimeter. So we can target areas like, dorsolateral prefrontal cortex. But for treatment of conditions like OCD or smoking cessation, where we target more deeper structures, they will use a different coil with more deeper penetration. And these are just an example of the coils and as well as the treatment protocol that I've already highlighted earlier. So the question is TMS safe and what are the side effects? So usually the symptoms or side effects are very mild and self-limited. Most common side effect patients' complaints are headache, discomfort or the stimulation side. And severe side effects such as TMS-induced seizure is extremely rare and is actually comparable to most psychotropic medications. So we can still be done. We just take precaution if the patient has underlying seizure, but we need to take caution if the patient have any metallic implant near the head and neck region, including cochlear implants, because we're delivering, powerful magnetic field. So now moving towards like how, efficacious is this TMS for our patients. So if we look at the multi-center RCTs that led to FDA approval or other meta-analysis, recent meta-analysis, they will say the response rate is around 50% and the remission rate with TMS is around 30%. The numbers may look small, but if you recall what I mentioned about the study trial, when they continue giving antidepressant at the 3rd line, 4th line, the remission rate reduces up to only 13%. So when we have 30%, which is double the amount, it's actually promising and may benefit more patients. And another question is when we say the RTMS induces neuroplasticity and so on, how durable is this antidepressant effect? So if we look at some of the studies, they say the durable antidepressant effect, about 50% of responders still able to maintain the benefit up to 1 year post-treatment, post-completion of treatments. And if we compare our TMS with other treatment that is being approved for treatment-resistant depression, for example, ECT or esketamine, our TMS is safer in terms of the risk factor, the side effect profile, and so it's more durable. So we know that efficacy of TMS for depression is well established, and also approved for OCD and smoking cessation. But the researchers are ever evolving, so we are now looking into other psychiatric procedures or indications such as PTSD, negative symptom of schizophrenia, and so on. So the next few slides, I'll be introducing or highlighting about our early experience providing TMS at our UMMC. So unfortunately, we don't have a TMS device at our psychiatry department, but we do have it at neuromodulation clinic at the rehab department. So for that, I must really thank Prof. Mazlina and the entire rehabilitation team for being very accommodating, for allowing me to do attachment, and as well as for allowing us to bring all our patients there to administer the RTMS treatment. So usually the steps are, once we identify or get the referral for RTMS, we will do screening, make sure patient is suitable, they are aware of what the patient counseling has been done, consent been taken, and once they're agreeable for the TMS treatment, we will schedule a first session that we call the mapping session. So this is the mapping call that's being used. So mapping session is mainly to measure and to locate the F3 here is the left DLPFC or dorsolateral prefrontal cortex. So here we use the beam F3 method where we first identify the vertex and then we measure the head circumference, and we have a specific calculation on getting the DLPFC, which is more precise as compared to the traditional 5.5 centimeter rule, which is we try to locate the motor hotspot or M1, and then the DLPFC is about 5.5 centimeter anterior to that, which is still being done, but of course, when you look at the beam F3 method and the 5.5 centimeter, there's more intra and inter-rater reliability. And if you're talking about precision targeting, of course, we have to move to neuronavigation, which is what we are trying to get, whether, a TMS device with neuronavigation for more precise targeting. So the next step will be, after locating the DLPFC, is again to measure the resting motor threshold. So we use EMG to get the motor evoked potential. Like I mentioned, it differs patient to patient. So once we get the resting motor threshold, that's when we set the treatment protocol. So for example, this patient uses the conventional protocol over the left DLPFC with 10 Hertz high excitatory protocol. And the power here is the energy that we use, which is 120% of their motor threshold. So each treatment, the patient is delivered 3,000 pulses, and the patient usually, like I mentioned, they require up to 20 to 30 sessions to achieve a good response. So this is the treatment call, which is different compared to the earlier mapping call because this has a inbuilt cooling system, so that the treatment can run for about 30 minutes without the coil getting heated up. And usually the first session mapping is done by the clinician, and then the subsequent TMS session can be administered by the TMS technician. But we do have clinician review weekly. One, of course, we want to monitor the side effect, assessment of the symptom, and as well as we repeat the depression scales to look at the improvement. And we also need to check the motor threshold, especially things like medication, sleep deprivation, or any substance intake can affect the motor threshold. And we also need to adjust the protocol as required. For example, some patients, when we give excitatory protocol over the left DLPFC, may start experiencing increase in anxiety. So what we do is we can switch the protocol to right DLPFC, giving more of inhibitory protocol that has helped as well. So that adjustment has to be made along the treatment process. So now I'll be just sharing some of our cases that we have completed. So we just started actively recruiting patients early this year to provide TMS for a psychiatric indication. So with that, we have close to about 20 patients that have completed. So for depressive patients, like I mentioned, a lot of patients were referred to me. They have a lot of comorbidities, not just pure treatment-resistant depression. They have comorbid anxiety disorder, personality disorder, even Parkinson. And I've also administered TMS for bipolar depression, although it's not FDA approved, but they have been researched so that they showed good response. And in this patient, she did show quite good response. symptom. And they did achieve about 60 to 90% reduction in symptom, and some even achieve remission of symptom of the depressive symptom. And these are patients who have been long-standing, say years, been diagnosed with depression, have tried multiple medications, even to a point of tried on esketamine and ECT, yet they still showed good response to TMS. It shows a quite promising, TMS is a quite promising treatment modality as well. But of course, there are patients who did not respond. So the patient profiling, if I look at the patients who did not respond, a lot of them has quite high anxiety to begin with at the baseline. So the thing about TMS, like I mentioned, is a long process, 4 to 6 weeks of treatment. So sometimes even the first 2 weeks, you may not see any adequate or significant changes or response. So a lot of these patients psychologically, they get very impatient, they get more anxious that the treatment is not working, and that itself, sometimes worsens the symptom. So in this kind of cases, sometimes we have to early termination. Some of them were referred for ECT. And I do have patients who did more than around 20 sessions. They do achieve about 40 to 50, almost 50% reduction of symptom, but they couldn't continue due to logistic reasons and so on. So if you would have continued the treatment longer, probably they would have, the response would have been improved. We're not sure, probably we have to see that. So with that, what is our future direction and consideration? So like I said, there is promising findings for TMS for psychiatric indications, but of course the resources, because the device is costly. And at this juncture, we only have a few places with TMS device, especially public universities. So if we are going to, get TMS device at many public hospitals and so on, we need we need to know whether the treatment is cost effective or not, which is one of the studies our team has been doing. Besides that, we need device training and certification, because in order to provide TMS, you need to have a certification, which is currently being offered at overseas. So we need to look into where, getting more staff being trained to get the certification course, and as well as TMS technicians. In terms of research, it's a very evolving area. Like I mentioned, for more precision targeting, we are looking into neural navigation system. And as well as now, it's no longer just about, targeting the DLPFC for everyone. Studies are moving to target using functional MRI to guide personalized RTMS, where we map the symptom to circuit, and then we give the TMS to, improve the, we call precision psychiatry. And of course, we have to look into, bringing in accelerated TMS, because the 4 to 6 weeks treatment may not be very feasible for a lot of patients, because sometimes I do have referral from other states and patient needs to come over and stay here for a month or so to get the treatment done. So accelerated TMS, if it can be done within a week, that would be very beneficial for a lot of patients. And of course, since TMS is still new in Malaysia, we still need to look into the regulation of practice, whether in public and private, and as well as having a insurance coverage will be very beneficial, as the treatment can be quite costly as well. Yeah, so with that, thank you. This is just a brief overview about TMS for depression. I'm happy to take any question.
Okay, so we have a few questions here. So the first question is, what happens if TMS is wrongly applied to patients with manic depressive illness? Do they become more manic during the manic phase?
Wrongly applied. Okay. So one of the thing that we need to, one of the side effect that we do counsel patient is the risk of hypomanic switch during the treatment process, even when we give excitatory protocol. So of course, if such things happen, we need to stop the treatment, and of course, optimize their medication, such as adding on mood stabilizer, and as well as if the symptom is very significant, causes any risk to self or others, then we might need to consider other treatments like ECT to control the manic symptoms. But for bipolar depression, so far from studies, the hypomanic switch is still not very significant, especially because a lot of patients on bipolar depression already has mood stabilizers on board. So the hypomanic switch is still low. So should I just go on? The next question is about any studies about TMS and autism in children. Yes, they do. Because even for us, we do have experience giving TMS for patients with autism, with mood symptoms, but they are adult patient. It's a bit more difficult in terms of monitoring, especially in the scales and so on. But they did show some form of better emotional regulation after the TMS procedure. As for children, we are not prescribing yet because it's not FDA approved, but I did came across some studies where they're looking into children at the age group of like about 10 to 12 years old for autism, and they showed some improvement in terms of the emotional regulation and the behavioral control. Any other question?
Okay, so since there are no more questions, so we would like to... Oh, there's one more question.
So another question is, how do you choose suitable patient for RTMS, only refractory depression or combined with pharmacotherapy and counseling? Yeah, so the guidelines, like I mentioned earlier, it mentions after 2 or medication failure. But if you look at FDA, even in US and all, the insurance does cover if the patient at the current episode, they fail 1 treatment. And counseling and medication occurs, is given concurrently. So even when we give start TMS for patient, their existing medication of psychotherapy is being continued and is actually combined. So some patient, the thing is when they are very depressed, it's very difficult for them to go through psychotherapy. So with TMS, when the symptoms start improving, what we will do is we even advise them to go for therapy and then to build their, coping strategies or as well as their resilience. And for some patient, if let's say they are very, even with 1 or 2 treatment, but they have a lot of side effect, they're not able to tolerate, those patients can also be considered for TMS, not necessarily have to fulfill treatment-resistant depression. Or if let's say, they have to go for ECT, but they're not keen because of the invasive requiring anesthesia, those patients can also be considered for TMS. Okay. How do we follow up after TMS? So usually here, okay, one, like what I mentioned, 4 to 6 weeks is the acute course of treatment, but they are looking into maintenance therapy, whether patients need follow-up maintenance. But at this juncture, there is no clear consensus to say that, maintenance TMS is effective. So what we do is usually after the 20 to 30 session, we will taper off the session about 3 to 1, meaning from 5 times per week to 3 times, 1 time, and then twice, and then once, and then we monitor, we observe. So most of the patient, if let's say they're able to maintain a symptom remission for 6 months, more than 6 months, and then if they come back after a relapse 1 year later, we just start do retreatment. But within 6 months, if they have, for example, any early relapse, then we will need to give something called booster treatment, where you may not need to give 5 times per week, but you can start out with 2 to 3 times session and then see build up from there. But most of my patients, after we complete TMS, they still follow up under their psychiatrist. If any problem, they will always refer back to us.
Okay, I think time is up for us. So thanks to everyone for all the questions. And I would also like to thank Dr. Hema again for the very important and clinically relevant updates on the latest options available to treat major depression and also treatment-resistant depression. So I will now hand over to the next moderator and speaker. Thank you very much.